On the 27th of July last year, shortly before 8 o'clock in the evening, I sat down in the Olympic Stadium to watch the opening ceremony of the London Games. As the minister responsible for the Games, it was a moment of great pride. 1 in 8 people across the world were watching, and London truly was the centre of the world. I also knew Danny Boyle was about to do something no one was expecting. Rather than trumpeting past glories like Agincourt or Trafalgar, it would be the modern NHS that he held up as one of the things that define us as a country. Why? Because for him, it was far more important to celebrate having the right values than winning the right battles. And despite the challenges it faces now, and indeed has always had to face, the NHS embodies those values. Britain is the best place in the world to be ill if you are poor or socially disadvantaged, because with the NHS, the quality of your bank balance does not determine the quality of your treatment. But if the Olympics were enriched by the NHS, so too can the NHS learn from the Olympics, and in particular the focus on excellence. Imagine for a moment that the main objective of our Olympic athletes was not to win, but to not come last. How many gold medals would we have won then? It sounds ridiculous, doesn't it? But today I want to suggest that too much of the NHS is focused on doing just that, not on achieving world-class levels of excellence, the gold medals of healthcare, but meeting minimum standards, the equivalent of not coming last. I'll also argue that putting this right must form an essential part of our response to Robert Francis's report into the tragedy at Mid-Staffs. Because by focusing on not coming last, avoiding the worst outcomes, we in fact make those outcomes more, not less likely. If the sum of our ambitions is not to come last, if all our attention is on the avoidance of failure, how much more likely are we to then fail than if our aspirations are to be the best in the world? Nye Bevan said that the worst kind of poverty was the poverty of low aspirations. We must never let that be said about our NHS. We often think of the NHS as infallible, the best hospitals, the best doctors, the best nurses. At other times, in the wake of things like Mid-Staffs, the pendulum can swing the other way. Neither paints an accurate picture. For in reality, the NHS is a huge organisation with some good practice, some bad practice, and a great deal that falls in between. But unless we create a climate of excellence in the parts of the NHS that are neither good nor bad, we will fail to address the cultural challenge that Robert Francis describes. Let's look at some of the surprising contrasts we have in today's NHS. At Leeds General Infirmary last December, 51-year-old former pub landlord Mark Cahill successfully received one of the first ever hand transplants, world-beating surgery. Yet last year in the NHS, we also had 326 never surgery events, including 70 wrong site operations, where the wrong part of the body was operated on or amputated. Or last month, a team at the University of Manchester proved that breast cancer stem cells can be targeted to stop the disease from returning and spreading, a discovery that could save thousands of lives. Yet in the international league tables for breast cancer, we come 16th out of 20 industrialized countries for 5-year survival rates. For colorectal cancer, we come 17th, and for cervical cancer, we come 19th. Even across the country, we have huge variations. If you get lung cancer in Kensington and Chelsea, you have a 20% chance of survival, compared to Herefordshire, where it's just 4%. The NHS was set up 65 years ago not just to deliver universal equity, but universal excellence. It's been much better at delivering the former than the latter. But if it's to live up to its founding ideals, then it needs to deliver both. So my question today is this. We celebrate excellence. We criticize failure. But do we do enough to challenge mediocrity? Because left unchallenged, mediocrity becomes entrenched and part of the culture. And that is precisely the moment of greatest danger if we're to prevent the next mid-staffs. The weeds of failure grow more quickly in a garden of mediocrity. Now, I would never describe the majority of hospitals or wards in the NHS as mediocre. But I do believe that our system fails to challenge low aspirations in too many parts of the system. This directly links to the failures of patient safety and compassionate care that we're now having to address. Because even if a hospital complies fully with CQC essential standards, even if never events really do never happen, it wouldn't mean that it was a good hospital, just that it was not bad. One of the biggest mistakes of the last government was to set up the CQC in such a way that hospitals, rather than being encouraged to aspire for excellence, were graded simply as compliant or non-compliant. The old star rating system failed because it was primarily about access targets rather than patient experience. But what succeeded it has compounded the problems rather than resolved them. One of the most reliable indicators about the quality of a hospital is whether staff would be happy for their friends and family to be treated there. So it's no surprise that the highest rated hospitals, specialist ones like the Royal Brompton and the Liverpool Heart and Chest Hospital and district general hospitals like Newcastle and South Devon, are amongst our very finest. They don't make a choice between compassionate care and meeting their targets. They do both. Indeed, the one links to the other. Failures in care or safety are not just unacceptable for patients. They lead to huge costs in both time and money for the institutions involved. Avoiding those costs means more time devoted to what people join the NHS to focus on: clinical excellence and compassionate care. But there are plenty of other hospitals, ones I won't name today, where their staff, friends and family scores are about the same today as they were in 2009. They're hitting their targets, they're not failing, but on the basis of this indicator anyway, they're standing still. Hospitals mustn't cruise along, hitting the target but missing the point. Because not bad is not good enough. Not if we want the NHS to be the best in the world. Not if we want everyone to have access to the best healthcare. Not if we are to meet the challenge of increasing expectation alongside increasing age. Which is why, even before Francis, I asked Jennifer Dixon and the Nuffield Trust to do one of the most important pieces of research anyone could do for the NHS and social care system. To identify whether and how it might be possible to rate and rank the excellence of health and care provision throughout the system. Not an easy task, given the failure of rating systems in the past, but not one we can duck either if we are to challenge entrenched mediocrity. Florence Nightingale said, "For us who nurse, our nursing is a thing which, unless we are making progress every year, every month, every week, take my word for it, we're going back." Coasting can kill, not straight away, but over time as complacency sets in, organizations look inwards, standards drop, and then suddenly something gives. As Robert Francis says in his Mid-Staffs report, the knowledge or belief that matters are the same or worse elsewhere can lead to the comforting conclusion that more cannot be done. It's an attitude that leads to inaction and continued tolerance of unacceptable standards of service. Instead of provoking urgent or more remedial action, a perception that a deficiency was common has led to a silent acceptance of it. So yes, we absolutely must be better at sorting out failing hospitals more quickly. But the lesson of mid-staffs is surely that we also need to understand why they fail in the first place, which means tackling low expectations before they turn into failure and tragedy. In his response to the Francis report, the Prime Minister announced perhaps the biggest single way we intend to put this right, the setting up of a new Chief Inspectorate of Hospitals within the Care Quality Commission. Identifying and rooting out failure will be a key part of its role, but so too will championing excellence. When Ofsted first named failing schools in 1992, they named outstanding schools too. And a new generation of superheads was born, people like Sir Michael Wilshaw at Mossbourne Academy in Hackney and Sir Dexter Hutt at Nine Styles School in Birmingham. People who would go on to turn around some of our most troubled institutions. We need more of that in our NHS, outstanding leaders like David Dalton, Sir Robert Naylor and Dame Julie Moore, who lead great organisations and can use their experience to help turn around underperforming trusts. People who understand how to instill a culture of excellence, of continuous improvement and zero harm to patients. And people who all know something else too. They know to put patients first. Let me give you an example from the Integrated Cancer Centre in London, run jointly by Guy's and St Thomas's and King's. When breast cancer patients came in for day surgery, they used to be asked to put on their surgical robes and wait by themselves until it was time. But that meant that at a time of great worry, they spent long periods alone, separated from their loved ones. So after listening to patients, they made a simple change to the schedule that now allows patients to wait with their family until just before the operation. A small change that cost nothing and made a big difference. And this is not the sole preserve of the big London teaching hospitals. In the 2010 National Patient Survey, Walsall Manor Hospital scored in the bottom 20% on more than half the questions asked. They were not in a good place, and they knew it. So they introduced the friends and family test. They now ask every patient very simply how likely they are to recommend Walsall Manor to their friends or family, and to name one thing they could do to improve their stay. From TV remote controls to warmer rooms to staff shortages, patient feedback led to fast corrective action, including focusing more resources in wards that were under pressure. A year ago, their own patient satisfaction scores averaged 65%. Today, they're up to 75%. In that same period, C. diff infections are down 80%, pressure ulcers down 30%, and falls down 20%. Not all of this because of patient feedback, but it is thanks to a new culture of patient-centred ambition. As Richard Kirby, the chief executive, says, it changed the nature of the discussion. Now, they're the first to say that they're on a journey, and they're not yet there yet. But they're on their way to excellence, and the cultural changes that have taken place give everybody confidence they'll achieve it. And from the 1st of April, every hospital in the country will do the Friends and Family test as well, and their results could change everything. So last summer, Team GB proved that they were amongst the best athletes in the world. But we should remember it wasn't always the case. Once we tried to gloss over our mediocrity, clutching our meagre haul of medals and consoling ourselves that we were the plucky triers, the valiant losers. And then in 1996, we hit rock bottom and won just one gold medal. That was the moment that everything changed. Losing was no longer good enough. Mediocrity stopped being rewarded. Inside British Olympic teams, it wasn't enough just to turn up. You had to be the best. And now, 17 years on, we pretty much are. That moment has come for the NHS, a moment of choice, a moment when we resolve collectively, not just never again with respect to mid-staffs, but that anything less than the best in the world is not good enough. A moment that has been too long in coming for the managers, the doctors and the nurses who know that things can and should be better, who thrive on doing the best possible job, who are passionate that in our NHS, world-class performance should match world-class values. As Health Secretary, I can't mandate that passion or enthusiasm in 1.7 million people. But I can seek to unlock what is already there and do so with confidence, determination and optimism. Because the values that made all of those people join the NHS are the values we now need to take it forward. Thank you.
So thank you very much for that. Perhaps a couple of questions from me, if I may, and then I'll ask the audience to see if they have any questions, if you would take them. Yeah. So the first question is, the NHS has really come in for some bad press recently. Mid-staffs, mediocrity, Bruce Keogh's 14 hospitals with mortality outliers. It's getting quite close to an election. Where do you think the gold medals are going to come in the health service to show to the public? Where are the wins going to be in your view?
Well, I'm not thinking about this in political terms. The election is more than 2 years away. I think when it comes to the election, people will ask a simple question. You know, is the NHS better now than it was 5 years ago? Have we got a government that's faced up to the big challenges that the NHS faces? The big challenges of an ageing society. There are lots of very big challenges that we have, and I want to be able to say to people that we haven't ducked those issues. The issue that has been brought into sharp relief by mid-staffs is the issue of compassionate care, of patient safety, of treating people with dignity and respect. And so much of the system is brilliant in that respect, but there are too many parts of the system where people on the front line feel that that is too difficult, that the system around them makes it difficult for them to show those values, to do the right thing, and that's what I think we have to seek to put right.
One of your predecessors, Alan Milburn, who sometimes comes to this conference, had a lot more levers in his armoury, if you can put it that way. I mean, he was probably epitomised the command and control culture that some say dogged the NHS and caused such trouble. But in moving this mediocre lump of providers, say, into excellence, what do you think now are your main levers that you have at your disposal, given what the reforms produced, which is at arm's length relationship between the minister and the commissioning board?
Well, I think Alan Milburn, I think incidentally, would agree with a lot of the things that I'm talking about in terms of using transparency and openness to tackle these problems. And I think he would also be the first to say that actually the lesson of those 13 years is that actually it isn't always the best way to change things for the better by ministers thinking that pulling levers, traditionally that's been by allocating money and setting targets, is the best way to do that, because if that's taken too far, it undermines the autonomy of people on the front line, and in extremis, which unfortunately has happened, you have situations where people look up more than look down at the patients who are in their hospitals. And so I think we want a system where we have greater autonomy. We trust people on the front line much more. We trust managers, we trust doctors and nurses on the front line more, but that we have rigorous independent inspection so that everyone, not just insiders, but the public and everyone knows how well someone is doing, and then we take very swift action when things fall before the standards they should.
You weren't here yesterday, but we had a session on the sustainability of the NHS, and we looked at some of the spending figures over the last few years, and what we saw was that there's been a jump in resources to hospitals and a slight decline in resources to primary care, which is interesting. Given that the long-term sustainability of the NHS is not necessarily about health of individual providers, but it's about pulling patients, preventing ill health and treating long-term conditions in the community better, how are we going to achieve that with that kind of resource distribution? And what is really going to pack the punch on this in the next few years?
Well, I think we need much better integration between primary and secondary, tertiary, and between the social care sectors as well. And perhaps we need to stop thinking about resources going to this sector or that sector and start thinking about the frail elderly, people who have multiple long-term conditions, who are the heaviest users of the NHS, and trying to develop, as has happened in some parts of the country very successfully, a system where within it people are actually blind to which part of the system they're on. They do what's right for the patient. I think technology can have a huge role. I think one of the things we have to crack is the electronic patient record that can follow people easily throughout the system wherever they go. I think that will reduce a lot of cost and bureaucracy. I think we also have to think about what we can do to free up GPs' time so that they are able to play a more proactive role in looking after the frail elderly, and do so more than just when they come through the surgery door, so that we avoid the sort of terrible situation where you have people with long-term conditions who are left on their own until they reach the tipping point when they have to be taken in an ambulance to an A&E. I think we all know that that isn't the best way of looking after those people as well as we can. But I think, technology integration, much closer working at a local level is the way that we tackle that.
I think on that theme, I think everyone in this room is probably has a consensus that reconfiguration is absolutely critical, and we have to transform the way we do care, and we have to reshape the provider terrain. And yet I also sense that there's mass frustration about how those decisions are often blocked, and that is the norm. How are we going to move forward on this key issue? And it strikes me that no politician has really been able to crack this, but yet this is precisely the time, if any there was one, that we have to really be braver than we have been.
Well, I think we have to, first of all, win the argument that when it comes to complex conditions, treating people in fewer places is actually going to save more lives. And I think there is there's certainly a very strong clinical consensus around that, but actually I think the public understand it as well. They look at what's happened to stroke survival rates in London, which have halved since the number of hospitals offering stroke services were dramatically reduced. And I think they understand those arguments, and even when it comes to highly contentious areas like children's heart surgery, which is obviously decisions are pending. So there is a big argument there, but I think we also have to reassure people, and this is where I think Bruce Keogh's work on the future role of A&Es is going to be very important. We also have to reassure people that when they need to get in front of a doctor quickly in an emergency, they're going to be able to do so. And I think it's getting those two things right. I also think that probably the best people to make those arguments are not politicians, but clinicians. That might sound like a piece of mega buck passing, but I actually think we have a lot of experience of politicians and managers trying to make those arguments, and we're often not successful at persuading the public. I think what the public want to listen to is someone they believe when it comes to exactly what is going to improve the care they receive.
A lot of MPs on the streets fighting for their local hospital. How is that going to be changed? Given what you've just said?
Well, you're speaking to one of those MPs.
Yeah.
I mean, I actually led the campaign to save A&E at the Royal Surrey, not very far from here, along with Alan Milburn, the Guildford MP, a few years back. So I know what it's like to be on the other side of the barricades. And I think we have to engage with those MPs. As the Prime Minister said, everyone wants to stick up for their local constituency. But we also have to engage with them in the arguments about what is actually in the clinical interests of their constituents. And I hold my hand up along with previous health secretaries, we have to be better at making that argument.
And just finally, just if the clinicians are key to helping to unlock some of these decisions, how are we going to get that kind of action from them quickly enough in the way that we need to get these reconfigurations moving?
I think the new structures will help. The formal independence of the NHS Commissioning Board on operational matters will help. The fact that we've got a structure where there are 4 tests that have to be passed before a major reconfiguration, I think will give the public comfort. But this is one of a number of challenges. I think reconfigurations is one issue. I think the way we look after the frail elderly is another very big issue. I think 7-day working is another very big issue. There's a series of very big issues, and I think it's really important for politicians to show a lead, as I'm trying to do this afternoon on the issue of how we create a culture of compassionate care, where the standards in all hospitals match the standards in the best. And I think if you make the right arguments, in the end I think the public will come with you, but you have to have the courage to make those arguments.